Good afternoon, everybody. So, as the chair with Luca, we are really honored to be the chair of the last session of this wonderful meeting. And as you see, there is a lot to talk about digital, and we're going to try to do it with two really master clinicians, two private practitioners. They're actually devoting their clinician to improve technology and digital. So Lukas Fürhauser from Vienna and Sergio Piano from Genova. They are really two master clinicians. We are enjoying very much working with them, and I'm sure that you will enjoy even more.
You will see that they are sort of visionaries, master clinicians. So they try to go a little bit further than what is the state of the art. So if I can have the clicker somewhere, thank you, thank you. Okay, so the theme of this show, of this session, is if these digital workflows that we are pushed towards are really game changers in our everyday life, and we have two people that are connected to that in everyday life, or are more a computer game, something that might be used for marketing, but that does not really help us. So, if I can have the first slide. This is a little bit the world we are talking about. Failing dentition does not go further. Okay, young lady, this lady came from Ukraine. She started her treatment when she was there, then you know what happened. She came in with these conditions. And now, you know the story. People would make a diagnosis, remove everything, place the implants in a guided way, and immediate load everything. And this, for sure, if you decide to go for this approach, the only way to go is to go digital. But this lady had some challenges. We also do, because it's not going forward. Okay. If you look at the X-ray, it looks like we have a lot of bone there. We have these teeth that I think no one will keep in a restoration. But if you look at the cone beam CT, if the video starts, try to advance it on yourself. Okay, you will realize that there is a severe horizontal deficiency. We have vertical bone, but we also have an horizontal deficiency. So what is the solution here? To do bone resection and try to find bone apically that, as you have seen, is not there, or to do something else? So in a case like this, do we really have a way to go with the standard protocol, or we have more to go through a personalized treatment plan that is not standardized and that involves other things than what we usually see in those meetings? And we will try to understand this with Sergio and Lukas. And so let's, before I give the word to Sergio, let's understand, because this is something that is not very often showed, that all these technologies have a huge cost, a huge investment. So before we think about implementing this as a routine in our everyday practice, we should consider who's going to pay for this. And so with this, I open the door for one of the two masters here, Sergio. Thank you very much. You don't need that.
Thank you, Luca. Thank you for your nice introduction. What a huge honor to be here on this podium as a part of this incredible Congress. So many, many thanks to the organizing committee for the highly appreciated invitation. And the title of the session is very stimulating. And my first slide takes one important aspect, how much the technology has impacted our everyday life in dentistry, and in this specific case, the treatment of fully edentulous patient or patient with hopeless dentition. And let me say, tool that in the last few years has, in my opinion, changed the scenario is the computer-guided surgery. I think that we cannot deny that thanks to guided surgery, we have improved the precision in the planning stage. We have at the same time improved the accuracy in positioning the implant, and we have found the best way possible to use the available bone that very often is a prerequisite for the treatment of a dental loss patient in terms of possibility of performing an immediate loading. At the same time, we have to say that in the last few years, other tools came into play, such as facial scanners, of course, intraoral scanning, and computer software that are able to plan a new smile. All this stuff has been very promising, and the aim is that thanks to these tools, we are able to simplify procedures. We want to have a patient more satisfied, and last but not least, we would like to reduce the treatment time. So, all together, I think that we can conclude that we have obtained several interesting things. The first is that now we are able to start our digital workflow and our workflow smoothly from the beginning of the treatment. That is very interesting. And more, the dental lab is involved in the treatment, and very often we are happy to plan a new treatment with 4 hands involved. So it is very interesting, this new approach that in the last few years is even clearer. And at the end of the story, the reproducibility of the treatment is another important point that must be highlighted when we speak about these digital tools. So, thanks to these tools, we see only positive things. I can say yes, but not completely, because thanks to this story, very simple animation, we can call him Mario. Thanks to Mario, we can highlight a point that very often is not focused too much. Mario is an dental loss patient. He's wearing dentures, and he wants to have fixed dentition. And so the classical treatment for this type of clinical situation is the placement of 4 implants, 2 of them tilted, 4 multi-unit abutment, and the screw retaining prosthesis. And this is what Mario usually can receive, but in the last few years, this treatment has been involved in a flow of a lot of strange new instruments that are very commonly used by the dentist. And the goal of the use of this instrument is, of course, to, let me say, simplify the treatment. That is correct. But linked to this interesting aim, we have another, let me say, dangerous situation that the simplification can be turned into a standardization. We can have a new, let me say, denture factory. All the procedures are similar to the others, and then the average dentist try to apply the same treatment planning, the same conclusion of the treatment planning to each patient. And this is completely wrong, because the standardization should be replaced by a personalization of a treatment. That means that that specific treatment belongs to Mario and to Mario only. And this is, I think, an important thing to be taken into account. I don't know what is your opinion, Lucas?
Absolutely. It's absolutely my opinion. I think the personalization and the individuality of our patient should be a main topic here, also in digitalization. So, I also want to thank for the kind introduction, and I also want to thank you that you're still here in the last session. And I also want to thank for this wonderful Congress to the SIDP, AIO, and the EAO. And I want to start with more personal essence of this session. I would say we shouldn't use new technologies just because they are trendy or modern. They should bring real benefits to our daily practice. So all of here and you, we are dealing with our daily problems in daily life dentistry. And we have to be very critical if new technologies are giving us a real benefit. So, and to make this a little bit more clear in our session, we have discussed this, that we are rating the technologies from a personal perspective, from an unnecessary computer game to a real game changer which brings us real benefits in our daily practice. So before we starting with the new technologies, I want to come to a very, very important factor, the main concerns of our patients. And in this very nice publication of Hof and colleagues, we are seeing that the #1 rank is the predictability of our treatment success. So this is the most important factor to our patients. #2, avoidance of removable denture. And only on #3, the cost efficiency. But it's important. So when we are talking about predictability, I think a very, very crucial point is that we are asking our patients how much you want to change your aesthetics and your aesthetic appearance. So when we would be in the same situation as these patients, would we like to be changed completely in our appearance? I don't think so. I think we would say we love our individuality, and Sergio was mentioning this before. This is very important, also for our patients. So we have seen that 61.5% of our patients said, I don't want to change my aesthetic appearance. 27.2% said, I want to have a minimal correction of my case, maybe a lighter color or a rotation of a tooth. And only 11.3% of the patients said, I want to be changed completely. So this is also an opportunity for digitalization and our intraoral scanners, because this is a very often neglected aspect, that with the intraoral scanners we can replicate the individuality of our patient and the initial dentition as good as we could never before. So this is a very, very important factor. When we are talking about avoidance of a removable denture, we see in this very nice publication, when we compared an immediate loading versus an early loading from the patient perspective, we see that we have significantly lower physical pain after the surgery, less psychological disability, higher functional score, and better aesthetic in these patients. An aspect our patients are always asking us about pain and swelling. And here maybe we have to talk about flapless or a conventional approach. And of course, we have to have enough bone and tissue if you're planning a flapless approach. This is clear. But does the flapless approach give an advantage to our daily life? Yes. We see that we have an advantage in the hard tissue, so less bone resorption, more buccal bone preservation. On the soft tissue, we can preserve the papillas much better. And of course, for the patient, we see that we have better results in the patient's comfort, and we have less pain and swelling after the surgery. So the last question, yeah? Please. Of course.
I think, can you hear me?
Yes.
Okay. When it comes to soft tissue, I agree that by doing a flapless procedure, you are preserving the papilla if you have the tooth. But if you have a healed ridge and you do a flapless procedure, you are not really sparing your keratinized tissue. Of course, you might have situations where you have a lot of tissue, but in some other situations, you might be in a critical...
Absolutely right, yeah. So the flap is often an
sometimes it's
advantage to save the keratinized tissue, but in the patients, in the cases you also showed, a failing dentition case, we see we can preserve with our immediate restoration and the flapless approach very good the soft tissues for our patients. And the last question I want to ask, if we should go for removable or fixed, this is very often a very discussed topic. So we know that a removable denture is easier to clean. We know that the cost effectiveness is better in a removable denture, because we don't need so many implants most of the time. And the invasiveness could be lower, especially in elder patients when we think about 2 implants with a bar or whatever. But when we look on the other side, so at the fixed reconstructions and again at the patient-centered outcomes, we see that they have significantly better outcomes in quality of life, comfort, functional limitations, and less physical disability. So when we are looking at the clinical parameters, we see no difference between these groups. But we have to have our patient-centered outcomes in our mind, also for the technology topic afterwards. So we will go for 2 cases, and Sergio is presenting Giuseppe, and I'm presenting Silvia. So normally it would be ladies first, but it's Giuseppe first. Yeah?
Through the illustration of these 2 cases, we will try to understand if the tool that will be presented along with the description of these cases will be a computer game or they can be considered as a game changer. So let me start with Giuseppe, whose initial situation is immediately clear, is a very, let me say, heavy situation, because we can immediately understand that many teeth are lacking in this mouth, both in the upper and the lower jaw. And what is immediately clear from the analysis of the facial profile is that the vertical dimension is roughly maintained, but what is totally lacking is the profile of the patient. That means that, sorry, the pointer was too fast. This means that the teeth, not anymore in the mouth, has provoked the collapse of the facial profile that now is concave. And I want to start by showing this upper arch, and there is a complete, let me say, disaster, because few teeth are remaining in the mouth. 2 of them are splintered for each side in order to assure a better stability and giving the possibility to chew more or less for this patient. The corresponding X-ray image show clearly that there is no hope for these teeth, and the only possibility to extract them and provide the patient with a solution that can be a fixed one as the patient required. And the lower jaw is not better. We have the central lower incisors that are protruding toward the opposite jaw, and they are also very mobile. Once again, the splinting of adjacent teeth in order to assure better stability. And the X-ray shows no doubt always possible to save these teeth. No, we are in a trouble because teeth are completely lost. Let me go on with the occlusal view that show a not bad situation for the point of view of soft tissues, both in the upper and the lower arches, and a promising situation of the crest that, of course, cannot be defined on these images. Next picture shows the frontal view and how this case should be treated, because the most difficult part is start with the appropriate planning. We can see the protrusion of the lower incisor on the upper arch, and the only positive thing is that the contact of the teeth on that side maintain the vertical dimension. It is a very important starting point for us. What we usually do in treating every patient, but of course also this patient, is a planning that is based on 2 points. These 2 points, I have to stay here because my pointer is not able to catch the signal. 2 phases. The first, of course, is a prosthetic setup that must be carried out considering who will be the ideal situation for this patient. And secondly, after having defined it, we can move the surgical analysis in order to understand how can we place the implant where and in which number. Of course, we start from the prosthetic setup that, let me say, has the goal to define an ideal smile of the patient. And this ideal smile is not easy to put into practice because we have no reference point. And one possibility is a computer planning of this smile, thanks to new software that now are available. They are very interesting because in this software we can define a new dental display by uploading of the software, first of all, the intraoral scanning, the frontal picture, the intraoral picture, and at this point, after having chosen the starting picture, the artificial intelligence propose a setup for this patient that must be personalized. You can work a lot and very into detail in order to provide the patient with the the best proposal you can have for that specific situation. Of course, different shapes, you have a lot of tools that can contribute to define really precisely what we would like to obtain in this patient's mouth. And nowadays, these tools are very powerful also in terms of pre-visualization, because the colors are very real, and this is what we can share with our patient. I think this is very interesting, let me say, from the point of view of the communication, because now the patient can understand what we have in mind, and this picture is nice or is acceptable for him or not. Of course, it remains a 2D image. So this is very nice for start our planning, but it's not enough to define a 3D disposition of the teeth that is fundamental to go on with the next step, so the surgical analysis. Nowadays, this new software allows you to go from the 2D into the 3D dental setup, because starting from this point, we are able to define, once again, thanks to the artificial intelligence, a matching between the picture and the intraoral scanning. This is done on the upper jaw, automatically is done for the lower, and then the software is able to propose an ideal setup that is in line with what we have seen in the picture, in the 2D picture. And it's very simple for us to make some changes that are very well personalized. You can see the axial images. Every movement is immediately visualized, not only in the axial view, but also in the facial image of the patient. So you can immediately understand that the tooth they are moving, they are changing, is impacted in the effort, with some effort on the main smile. Of course, any change can be done. At the end of the story, we are able to export from this software an image that is STL file that in our hand is the best possibility that we have nowadays to transfer something that is almost real into the computer for the second analysis, so the surgical one. And this is the following step. So this STL file is imported into the computer. Moving to the next picture, we can immediately say that if you ask me, do you consider this planning as a computer game or a game changer? I can say yes, it can be considered as a game changer. But if you make me another question, so if this is the only way I have in my hand for doing planning, and this is the way I treat every patient, if I want to be honest, I have to say no.
Sergio, one other question. How long does it take for you to do this planning? And how long did it take for you to learn how to use this software?
A lot of time. A lot of time is spent. But I also to say this makes me more comfortable when I go on with the surgical.
So it's an investment that makes your life easier.
On my health.
Yeah.
Investment on my health, but I have to admit that I spend a lot of time in doing all this big work on my computer.
That's a reasoning reply. I mean, you invest a lot of time, but then everything is set and you go there.
Exactly. I can play more relaxed when we will see later in a video of the clinical execution. I think this can be run smoothly and without problem. So in the majority of the case, of course, but nevertheless, of course, the learning curve is long, and the time invested in creating this approach, the same story. So it is not my average treatment for each patient, because there's another type of solution that is a classical one. So every time that is possible, I like to check this setup in the patient's mouth, because it's the best feeling we can have back from the patient by showing a very nice smile. And this approach is my first choice when the treatment is an edentulous, because it is very easy. We have our background from complete denture. Everyone is able to create a setup in a classical way, check in the patient mouth. With a very analogical situation, we can also paint some part of the lower teeth in order to give the impression, the idea that the teeth are shorter. But this is easy to do, very convenient, and very effective, because thanks to this immediate pre-visualization, we are able to understand the impact on the smile and on the face of the patient. And this is how the case was carried out, and the corresponding X-ray image and the smile of the patient. Not only in the dentulous patient is the first choice, sometimes the non-dentulous patient can obtain a great advantage of an analog approach. A case like this one, where of course we have to redraw a smile of this hopeless dentition, can be beneficial. The use for this patient can be beneficial, the use of a traditional approach, because we can visualize very well the dental display in this mouth. You see a frontal view of what the dental technician created in this mouth. A part of it is done with the wax-up. The posterior one is treated with a setup, and thanks to this pre-visualization on the model, we can bring it into the patient mouth. You see the lateral view, 2 rows of teeth, but you will see in the mouth it is quite clear how to impact in the aesthetics. And thanks to a silicone mask, we are able to transfer the wax-up into a mock-up by means of some flowable composite. And in the posterior, we added the setup, removal setup. And this is the impact of the smile. We can immediately understand if there are mistakes, we can make a correction, we can work physically on this setup. That is a possibility that nowadays is not completely possible on the digital plan. And on top of that, we can have the patient moving, smiling, chewing, speaking. And so this is an incredible possibility to have under our eyes the effectiveness of this approach. By the way, this is the final rehabilitation that was done, of course, in line on what we have said before. So the mock-up was done with an analog approach. Sometimes, or very often, there are cases where it is not possible to perform it in a direct way with a physical, let me say, check of this setup. It is a case like this one, where you have a great protrusion of the upper incisor. This means that it's not easy to visualize the line, the smile line, and on top of that, we also have the risk that if you provide the patient with a mock-up, as soon as you remove the mock-up, probably these teeth can be extracted. So it's too dangerous to perform a traditional mock-up, and a case like this can be a perfect candidate for the treatment with a virtual or digital, as you like, planning of the smile for this case.
But, Sergio, in a case like this, it's an advanced periodontal disease for sure. We didn't see the x-rays, but I think you know them by heart. You probably expect the transition line to be hidden under the lip.
Yes, this is another interesting point, because
does this, since we're going to probably end up with an FP3 prosthesis, does it make all this sense to have this fancy pre-surgical diagnosis if at the end of the story you're going to end up with a prosthesis where you can adjust the parameters as you wish?
Yes, I can understand very well what you're saying, and I have to add that, of course, if the prosthesis is a FP3-1, probably the accuracy of the planning can be a little bit less, let me say, detailed. Nevertheless, I think that is important to understand which kind of rehabilitation we want to plan in that specific case, how the teeth are protruded, so we can also understand where the implants should be placed, considering where is the the final solution for that case. So I think that the planning is always
Beneficial.
Yes, interesting to do, and it is beneficial for both cases.
I think so too, yeah. Planning is the key. So now
It's your turn.
it's so now the lady is working through the door. I want to introduce Sylvia. She is 72 years old, and her main concern is she wants to have a fixed reconstruction. This is really important for her. So these are the extraoral pictures. These are the intraoral pictures. And I think this is very important that we are doing this documentation. I think no orthodontist on this planet would start his treatment without doing photos, so we should do this as well. This is very important for our planning. What else is very important for our planning? I think the 3D dimension, we always have to have a scan in the beginning. Why is that so important? Because if we are losing track in this long procedure, it's very, very important that you have that you're able to go back to your initial situation if you have any problems. So if you have a problem in phonetics, if you have a problem in mandibular joint, it's always very valuable to have the initial situation and to be able to go back to the initial situation with your reconstruction. We don't want to, but it's important to have it. Another thing which is always in our standard procedure is a pronunciation video, because we know from the literature that around 30% of the patients has a phonetic problem after the transition from failing dentition to a new reconstruction on implants. So this is very important that we have a documentation about the pronunciation of the patient before we extract the tooth, because it's not possible to redo this video when you have extracted all teeth and you don't have the initial situation anymore. So we'll let count the patient from 60 to 70. Why is that? Because we know that the S sound is the most affected sound when we are doing a new reconstruction. So this is really important for us. We are doing this in the beginning and also at the end of our treatment. These are the clinical videos. So you see a lot of mobility in the dentition. You see a mobile bridge. And this is the panoramic X-ray of the patient. And this is the single tooth prognosis. I think we have to be very sure that we are extracting so many teeth. So we have to take our time to do a single tooth prognosis. So I would rate these two teeth as uncertain, but I would rate the other teeth as hopeless. So it's very difficult to achieve the goal of a fixed reconstruction with only two teeth on one side. So here we have to go for an implant treatment to get a fixed reconstruction. So the patient told us, I don't want to be afraid of laughing anymore. This is important to me. So here we can't replicate the initial situation. Here we have to go for major correction. And it's very, very important that we are doing a very good aesthetic analysis before we start our treatment. I'm always doing this with the patient together on a printed photo, and I think this is very important that the patient can contribute to the aesthetic change in the beginning of the treatment. And it's also good to have a printed photo and not a mirror only, because it's good to have the same perspective at the same time. So we want to correct the midline in this patient. We want to correct the axis angulation of the teeth. And from my perspective, the length of these teeth is a little bit too long, and also from the patient's perspective. So what we are doing, a very analog approach, but it gives us just a little bit of orientation where we are heading to. So we have here, we're just coloring the incisal edges of the patient, and then we are putting some composite on the gingiva and the initial bridge, because then we can have an estimation about the healing and the new transition zone we're expecting after the treatment. So this is just an orientation to see if we're heading in the right direction. So we see now why the patient has a midline shift. We see that the canine is in the bridge second incisor position. So we have an agenesis of tooth 2-2, and this is very important for us for the implant planning afterwards, because we know we want to shift the midline. If we are using the alveolar of one of these teeth, we would do this in a normal case when we have not a shifted midline, but in this case, if we would use the alveolar of the dentition, we would end up with a not perfect midline, or we would end up with an implant in between two teeth. So this is also a problem for cleaning afterwards. So this is a situation also Sergio was talking about before. We have a loss of vertical dimension, we have a protruded aesthetic area, and now it's very difficult with an analog approach. Why is that? Because when we are doing an analog approach, we would do a mock-up, but it's very difficult to be even more protruded. This is not the situation we want for the patient at the end. So what we want is a retroinclination of these teeth. We want to have a shorter teeth and a corrected midline. Do we have technologies helping us in this aesthetic analysis? Yes, a facial scan is very beneficial. Why is that? So you can do this with a handheld device. You can even use your smartphone, but this is sometimes a little bit difficult to align the intraoral scan with the smartphone device. So these dental devices for facial scan has already included a software aligning these two scans, and this is the crucial point. So now we're in the lab software, and it's amazing to have to speak the same language with the technician, because in earlier days we had the problem, we have a 2D photo, we have a perfect analysis, but afterwards we have to translate it in a 3D data, and this is really difficult for the patient. It was very often not very precise. So in this case, we just did a virtual setup for the patient, and the second aspect, which is really great, that we can transfer this setup to our planning software. So we see here the initial situation and now the new situation, and we can perfectly align the implants to our new position where we want to have the final restoration. So for me, the facial scan is a real game changer, because I think we're saving a lot of time in adapting our restoration in behalf of length, axis angulations, and also the midline. So I think it's a very helpful tool in my daily practice.
After the prosthetic setup, of course, we have to move to the surgical analysis. We are back to Giuseppe, sorry. And Giuseppe now has received a planning of the smile, but nothing is done till now. We have to decide how to translate it into a surgical proposal. And now it's time to work on the software that is a computer-guided software. And nowadays, these software are very performing, thanks once again to artificial intelligence that makes a very nice and very clear segmentation. On top of that, is able to virtually extract the teeth and visualize very clearly the condition of the socket after this extraction. This can be very useful if you want to plan of placing the implant in that sites. Of course, the process is carried out by matching the initial situation, the opposite jaw. On top of that, we have to match one of the most important data, that is the smile of the patient that we have received from the planning we have on the other software. And this is the base of our treatment and the final goal we want to obtain at the end of the treatment. And on this basis, we have, of course, consequently, the lower dental display. And we start to plan the position of the implant. We choose the abutment, the multi-unit abutment, straight and angled. And on top of this, of course, we can, in any case, see how is interesting this planning and how is accurate, because we can, by choosing the appropriate coping in terms of diameter, in terms of gingival height, you can easily and very successfully understand which would be the ideal emergence profile and start to describe the contour of our bridge. And this is not done only in single reconstruction, but this is now possible and predictable also in full arch reconstruction. So this is very interesting, and we have to to use this opportunity to start on conditioning the soft tissue by deciding relaxed on our computer, which is the ideal abutment for that case of that site, and which is the ideal emergence profile in combination with the design given by the setup. Of course, what we have said till now is something that is virtual. All is done on the computer. So you can say, yes, very nice, I love it, but till now it is completely a computer game. Nothing of, let's say, physical is seen till now. How to turn it into a game changer? And I think that the point that can translate what we have done in the computer in something real in the patient mouth is the use of stackable guides. Stackable guide has been introduced in the previous presentation, last session. I think that are a very interesting tool. We need a guide that defines a reference point that is the base guide, the metallic one. You will see the video very well later. This is only an animation. And this reference point given by the base guide is connected previously to a dental guide that gave the contact with the remaining teeth, the stable ones, and the palate, in order to give a reference point for the positioning of the base guide. The base guide is blocked into the maxilla by means of fixation pins. At this point, we remove this padlock, we remove the guide, and now we have a stable guide that it will be the base of the first steps, and we have a very comfortable situation for the prosecution of our surgical phase. In fact, we can start by extracting the teeth. We can sit on top of the the surgical guide. The surgical guide is strictly fixed once again by means of a couple of little padlocks. And now we start to place the implant accordingly to the protocol you usually do in case of computer-guided surgery. Once done this, we remove the pin, remove the guide, and then we can screw the abutment we have chosen on the computer and the temporary coping. And the last step that is very interesting from my point of view is that on this base guide, we can see also the prosthetic guide, that is a guide containing the setup that is at this point the temporary bridge, and then we have a very reliable position, no stressing in placing the bridge in a more or less a certain position. We have a very quick way to define which is the ideal position of the provisional bridge. This is fixed by means of the padlock, some resin in between the temporary coping and the bridge, and then removing once again the padlock, we have out of the mouth the bridge for the refinement. We remove at least at the end our base guide, and then after the refinement we can deliver the provisional bridge in the same surgical session. The same can be done in the lower jaw. I go quickly because the procedure is still the same. Matching of the data, planning of the implant and the abutment, creation of the base guide, the surgical guide, and the provisional guide that allows to obtain a final result. Let me show the surgical execution.
Sergio,
Yes.
excuse me for bothering you, but how much do you pay for the guides and the provisional, roughly?
Roughly, we are talking about 1,000 euro per arch.
Okay.
Something like this, 1,000, 1,100, 1,200. Depends on the material and the personal cost of dental technician, but roughly,
Okay.
This is the cost. So, in this way, we are able to plan in advance all the detail. I said before to Luca, I want to work relaxed. This is, in my practice, the best way to simplify my surgical treatment and to try to avoid all the problems that I can face during the surgical phase. This is the video. This is what we need for the upper jaw. The first point is to link together the base guide with the dental guide by means of the padlock. Now we are ready to go to the patient mouth. Very important to precisely define the right position in order to fix the guide to the maxilla. Then we can remove padlock and the dental guide, the removal of the teeth, And now it's time to position the surgical guide. We punch the site, of course, without fixing the guide. Now it's time to strictly fix the guide. This is important to have a very stable guide. It cannot only lie on top of the base guide, must be linked very firmly in order to be sure that we are very stable in this drilling procedure. We need a drilling procedure very, very smooth. The same for implant placement, very accurate. It is done for every site. We remove the surgical guide. We screw on top of the implant the straight and angle abutment. After this phase, we tight on top of it the temporary coping, and this is the turn of the prosthesis. Now the prosthesis is very, very smoothly seated on top of the base guide. We fix it, and now it's a piece of cake. We just need to add some resin, wait for the polymerization, remove the prosthetic guide, and now it's time for the dental technician to start to refine the bridge. In the meantime, we remove the base guide. This is how the bridge is out of the mouth, and we start treating the lower jaw. The same approach, same pieces. We can link together base guide with the dental guide. We check it carefully. We need to have a perfect contact. This is a crucial phase. And then we block it into the mandible this time, removing the padlock and removing the dental guide. The teeth are out, and now we start to place the implant. Exactly the same protocol, despite the fact it is a complex case, but we have planned it very well. Punch and mini flap in the frontal area where we have not good availability of attached gingiva, the usual drilling procedure, and the usual implant placement. Tissue level implant and bone level on the lower jaw, and bone level implant on the upper jaw. The temporary coping, the temporary bridge. Once again, it is easy to fix it without any interference of the tongue. The patient is moving, all this stuff that make this procedure sometimes difficult. Removal of the pins and removal of the bridge, along with the removal of the base guide. And this is what we see, the stitches in the mini flap in the frontal area. After the refinements, half an hour later, the bridge in the upper jaw is ready to be fixed to the maxilla, and the same has been done in the lower jaw. And this is the most important part, I think, because after this long work, we are able to find easily the correct occlusion, that roughly is okay, only little refinement, but we have solved this case playing very, very safely and in a relaxing atmosphere.
Sergio,
yeah.
I have a question, because I saw that you made a mini flap, just to manage the keratinized tissue. How easy is to work with the stackable guide in place to do this flap management?
Yes, you have different options, but if you think that in your specific case you need to raise the flap, you should plan the design of the base guide considering this possibility in a way that you can raise the flap and having still the space for sitting the other guide on top of it. Alternatively, if the flap is very big, that is not the case, but in case of bone resection, something like this, you can firstly raise the flap and then sit the guide in order to have the bone under your eyes easily. So
in any case,
nice question.
You're trying not to remove the guide from it.
Yes, I think that one of the crucial points is position the base guide and leave it till the end of the procedure, because the continuous removal of the base guide can lead to imprecision, and it's also difficult sometimes to find the holes, because there is blood, clinical condition that can make this procedure difficult. And so what I suggest is to use a base guide and to fix it and do not remove till the end of the procedure. And this is what happened after the surgery. Of course, the pictures are taken 2 days later because the patient was quite tired after the procedure. And look at the tissues. So we are able to, thanks to a very nice and precise planning, we are able to have from the beginning a good tissue condition, a good tooth profile, and so we are happy with this. The upper and a complete view of the mouth of the patient just 2 days later, and the corresponding X-ray image showing that we are on the right track. And the most interesting picture is this one, the change that we have seen in the face of the patient, not only in the face, I think the mood of the patient is completely changed. So this is something that is the best result we can obtain in a case like this.
Sergio, we have a nasty question from the audience.
Yeah.
They say when you were positioning the main guide and you use a dental supported guide and you understand that it does not fit to the dentition, what do? You abort everything?
This is a big problem. In fact, you always need to have a second solution in your head because something can go wrong, of course. We have to say that if you have some existing teeth and you sit the guide on the existing teeth without me doing any extraction before starting the surgical phase, you can check it before the surgery.
And we all know that the most precise repositioning is when you fit your guides on the teeth.
Of course.
So this is pretty well demonstrated in the literature.
Just to show some picture, 7 days later, the healing of the tissue, that is very nice in my opinion. I go faster, and 3 months later we have the healing of the tissue and the corresponding X-ray image. Some slide very quick to illustrate how was successful, in my opinion, this procedure. And before and after, I think is evident how the patient has improved his aspects. And 3 images of the face, frontal view, lateral view, a half lateral view of this patient. If I have to say, stackable guide is a game changer, in my opinion, it is, because it's a tool that can make me more comfortable with the treatment, allows me to treat a complex surgical case in an easier way, and so I think that I can say this is a tool that I can keep into consideration.
So we are back at Sylvia.
Sylvia again.
Now we're in a shared decision process. We want to have a fixed reconstruction. So we have different surgical approaches. I'm not so often discussing with the patient because I'm the prosthodontist, but we're always doing this together. Why is this so important? So we have one option of 4 implants with 2 angulated implants. We have an option with 6 implants and a sinus lift. And we have an option of 6 implants, a little bit of a mixed thing of an all-on-4, and a short implant in the distal area, so 8-millimeter implants with a Summers osteotomy. So when we are talking about these concepts, we also have to think about the prosthetic concepts we want to use at the end of the treatment. So when we are talking about 4 implants, we will have cantilevers. Are cantilevers a problem for our implants? From the literature, we know it's not. So we have not another survival rate, or we have more marginal bone loss. This is not a problem for the implants, but it could be a big problem for our restoration, because we see in literature that we have more chipping in bridges with cantilevers. So it's very important that you know the material you want to use at the end of your reconstruction at the beginning of your planning, because you have to know how much prosthetic field I'm needing for my restoration. So for example, when you want to use a monolithic zirconia, the prosthetic field is very, very crucial. So in this case, you would go more for 6 implants, either with a sinus lift or with 6 implants and distal shorter implants. So in the middle, we have 6 implants with a sinus lift. So we have more treatment time, we have a higher invasiveness, a little bit more morbidity than in the other 2 options. And on the right side, we have 6 implants with a shorter implant. Is a shorter implant a problem? We also know that from literature that we have very, very good outcomes and comparable outcomes to longer implants. So in a 4 implant treatment, the second aspect is if you're losing 1 implant at the end of your reconstruction, So when you're always finished with your final reconstructions, it's very often the loss of the whole reconstruction, because it's very difficult to realize a fixed reconstruction only on 3 implants. So we have a little bit more safety when we use more implants than 4. And we discussed with the patient, we want to go for this approach. So now I want to talk a little bit again about new technologies, dynamic navigation. What do we know about dynamic navigation? What is the basic principle behind it? So dynamic navigation is using 2 infrared cameras tracking the reflection of a marker. So it's the same principle. We are using our eyes for a 3D dimension. So when we are closing one eye, it's very difficult to have a distance estimation. You can try it out. It's very funny. It's really difficult for our brain, because we have 2 eyes watching an object from 2 different angles. And the same is in dynamic navigation. So we have 2 cameras watching an object from 2 different, or filming an object from 2 different angles. So this clip is a connecting link between the patient and the digital planning. So it's very important, because here the marker is screwed on. And the camera has to see 2 objects. So on the one hand, the patient, because if the patient is moving, your CBCT and your planning is also moving. And on the other side, you have to see the instrument, because you want to see where you are drilling at the moment. So now we are going for surgery. We have the extraction of the left side. We clipped in the clip on the right side, and then we started with the first drilling sequence. This is region 2-7, and here it's very nice to have a live navigation, because you can very precise drill underneath the sinus floor, and with the osteotome you can very nice elevate it to place a longer implant. So this is a great advantage in this region here. This is drilling sequence of 2-5. We see here a little bit on the right side, we are not perfect in the planned position, but we see live that we are still perfect in the bone. So this is not a big problem. And maybe the most important side, we have talked already about that. So we have the midline shift. We want to shift the midline to the right of the patient. So we are here a little bit in between the alveolus to have a perfect implant alignment with our teeth afterwards. So this is very important. I just summed up the other side, because the same procedure on the other side. And now we have to talk about how precise is dynamic navigation in a full arch case. And we see it's very precise. We are almost as precise as with static guides, so there is not a significant difference between the 2 guiding systems, but it's both better, or significantly better, than a freehand procedure. So when we are talking about dynamic navigation, we have to do pros and cons. So on the positive side is, it's great to see what you're doing at the same time. This is really great. We know, we have seen it already, the precision and the accuracy is very, very good of this device. And you can, of course, change plans. This is the big difference to a static navigation, because if you want to place another implant because of insertion torque and you want to do immediate restoration, you can plan it during your surgery. That is a real advantage in dynamic navigation. So the negative points is, in a static navigation, you have the preparation time before your surgery. So you have the time-consuming part before the surgery. In the dynamic navigation, you have the setup time, so the connection between the different parts and your drills and the marker of the patient within the surgery. So this is a very valuable time, we all know. So this is a little bit annoying. The clip can be an obstacle. So when you're hiding the clip with your arm, that could be also very annoying, and it needs a little bit of learning curve, a longer learning curve than with static guides. And we are always focused on the computer. What could we do about that? So we have implemented augmented reality glasses in the procedure. We are not using it on a daily basis, but we're working on that, so that you can look as a surgeon in the patient's mouth at the same time you see your navigation. So this could be a game changer, maybe in the future. So if I rate a dynamic navigation at the moment compared to a static guide, I would say it's a little bit on the computer game side, because we know that static navigation, we have seen it in Sergio's case, is working very well, and the price is pretty high for dynamic navigation. But if we can shorten up the setup time in the beginning, so the connection of the different parts, and if we have to focus on the patient at the same time we see the planning, I think it could be a game changer in the future. These are the implant sites, and we also see the primary stability torques on the bottom. So very important for us is the bridge insertion torque. We want to be here over 35 Newton centimeters. This is very important to load our implants with an immediate restoration. So we have done it also here. We are adding all implant numbers. You were wondering why it's only 4 and not 6. We excluded the 2 implants in the distal area from this immediate restoration because their insertion torques were not so high. So now we have a bridge insertion torque of 43.75, so more than 35 Newton centimeters. Another very, very, very important question is, do we need abutments in our daily life? So multi-unit abutments, low profile, so whatever you want to call it. From our perspective, this is a very, very important factor. Why in the time and the era of Morse taper implant connections between the reconstruction and your implant, it's very difficult to get a perfect sealing with a multi-unit bridge without abutments. So for us, the sealing of the implant is very important. And the second aspect, which is really a daily aspect from daily life, it's very important also for the patient to be on the tissue level, because when we have the patient for hygiene, we take the bridge off every year or 1.5 years, so the patient are not coming very often if it's very harmful and painful. So we know that also for the patient it's a big benefit to have an abutment. We also see this in literature, so when we look at the data, we see that we have more marginal bone loss at no abutment sites compared to abutment sites. And now we're in a very, very, very interesting topic. Are we doing intraoral scanning for full arch? This is a very difficult answer. This is a very difficult question.
Lucas, because so far you don't have the provisional restoration.
No, we come to that. So, to compare these 2 columns, I would say we have on the left side the pro intraoral scan group. So here we say we are in the acceptable accuracy of our scans in daily life. And on the other side, we see the publications which are saying we are better with impressions and please don't do intraoral scans. So it's very difficult to answer these questions. But Sergio, what would you say? I think in our daily life, we are doing intraoral scans for full arch. There is a certain scanning procedure, which is very, very important. And I think we also think that we are in the acceptable boundaries of clinical accuracy. What do you see in your patients?
I agree with you. It is more difficult to scan the lower jaw. That sometimes can be a real nightmare. But for the upper jaw, we are more confident for this, for sure.
Yeah. So now we are going for the immediate restoration. So we wanted to show you different approaches. We had here the stackable guides with an immediate restoration already finished before the treatment. We are doing the immediate restoration after the implant placement. So how we are doing it? So we had a very, very long learning curve in this scanning procedure. It was painful because we had a lot of mistakes and we had a lot of errors during this phase. So we're doing this around 10 years now. The most important scan in the scanning procedure is the initial scan. Why is that? Because it's very difficult to take a bite with an intraoral scanner without teeth. It's not impossible, but it's very difficult. So we are doing a pre-scan, upper jaw, lower jaw bite. And then we are using the information from the first scan in the second scan. So we always leave one tooth in the mouth when we are scanning full arch for the scan, because it's very important Why? Because the scanner already knows this tooth. So we are deleting everything else, but we have one tooth still in the mouth, and we are starting our scan at this tooth. This is really important for us. Then we can extract the tooth when we have the emergence profile, and then we are scanning the scan bodies. We always start the scan for the scan bodies at the middle of the palate. This was also very important for us in our accuracy. So at the beginning, we started at one side and we're going to the other side, like we are doing it in a dentition. But we have seen with the stitching problems, we have a magnification of our errors around the arch. So we are starting at the middle. And maybe the last point in scanning, which is really important, is that you're not losing your flow. If you're losing your flow, please start at the middle of your palate, so at the beginning where you have started your scanning. Don't start at any scan body. That is really often very confusing for the scanner. So now you have all scans, and these scans you can send to your laboratory, and see here's the bite, the length, lower jaw, upper jaw. Sergio, do you have some tips and tricks for us?
Yes, discussing about how to make this intraoral scanning less complicated and more reliable. There are some tricks that you can take into consideration, because this situation seems to be nice, but when we are facing the situation where you are already screwed the scan body in the mouth, the scanner is not so easy in find the right path along the mouth and doing the right scanning procedure, because he is losing his way. And so there are some tricks that can make the work life of the intraoral scanner simpler. And so giving some help by giving to the scanner some reference points, once again. And one trick is to place some composite balls on soft tissues. This is a way to facilitate the movement of the scanning. They recognize this ball in certain position. They can understand very well if in this moment is not considering this or this, but it takes advantage from the position of this ball, considering that it now is close to this scan body. Another possibility is to link scan body together, as in this case, a rubber band that very easily can be used like a connection between the scan bodies, and this gives a sort of path to your scan body in order to understand if you are really in that specific part of the mouth, because all these parts are very similar, so the intraoral scanning can be confused. Another little trick is the possibility, in order to avoid this misunderstanding of not recognizing which is the position of the scan body that is scanning, we can use different types of scan bodies. It means that, of course, you have to remain, my suggestion, in the original components of the company. Don't use fake. But several companies produce different shapes of the same type of scan body, so you can make alternatively the green, the gray one, the white one, the green, the white, the green. And in this way, the intraoral scanner, once more, can find the right path. And last, the possibility to fix this type of, we can call them clips, wings, as you like, that once again has the role to define a way for the scanning and understand what it is. This is a difficult case to scan because the palate is very flat, there are no wrinkles, so this intraoral scanning can get lost in scanning this palate or this upper arch.
And maybe to repeat it, the scan in the upper jaw is much easier than in the lower jaw.
Of course.
So all these tips and tricks are really helpful for the lower jaw. For example, for an immediate restoration, you have bleeding sides, you have the lingual part which is moving, the lip part which is moving. So often you need a guiding structure, and there these helping tools are really, really great. So now you're seeing the immediate restoration. Sylvia got it already. 2.5 hours after implant placement and scanning. And maybe you will ask why we have left this open space here and not blocked it. But when we are looking at the 1 week postoperative picture, it's very nice healed at this site. So the immediate restoration is not only for the patient to avoid the removable denture, it's also a guiding structure for our soft tissue. So this is a very important tool in our reconstruction, because here we can move and attach everything as we want it. So the provisional is not only the provisional, and we're doing much better in the final restoration. It's a very, very important factor, and it should be as precise as possible. It's the prototype of the definitive bridge you want to deliver at the end. So 1 week of healing, and then we are at the extra all pictures. I think we corrected the midline and the length of the teeth very well. And then we are in a very interesting question. Material of provisional restoration. It's very difficult to answer that from the literature side, because there is not so much literature about resin which we are using for an immediate restoration. So we have an old concept we have done before 2015. We were using a fiberglass splint, splinting the implants, and used acrylic teeth. It was a very stable solution, but we had a lot of chipping. Then, after 2015, we were using CAD/CAM products, which are great, and I love them. But at the beginning, we had a lot of fractures. So this was a very big problem for us, because we have seen that they have a significant influence on our healing rate and our implant survival rate, especially at the beginning, because the splinting of the implants in an immediate restoration is absolutely important. So we have used a lot of different materials, and at the moment we are using graphene reinforced resin. A very nice German colleague told me this, I think, 3 to 4 years ago, and we used it, and it's a great material. And when you want to look in your manual instruction of your material, maybe the most important factor is the bridge pontics, how many bridge pontics you're allowed to do with your material, because when you're doing an all-on-4 treatment, it's very often the case that you have more than 2 bridge pontics between the implants. So this is a very important factor. Now Sylvia is 4 months after the surgery, and we see maybe we could have a little bit better gingiva contour. And another aspect of the immediate restoration is that you can add something on the immediate restoration. So we are adding just some composite to condition the soft tissue a little bit. So when you are putting composite in the buccal part, it's very important. It's, of course, you get longer crown length. So if you want to have a longer crown length, this is perfect. But if you just want to have a more realistic profile of your crown, so it's very important that you're adding composite at the palatal side. So you're not affecting this buccal area here, where we are shifting the soft tissue apical. So this is the picture after the soft tissue contouring we have done, and now we are again in the full arch scan procedure. So we have said before, the pre-preparation scan is the most important scan for us. Why? Because we have to take a bite. So now we are using the provisional restoration to take the bite, and then we are using the information of the previous scan. So we are again deleting the provisional restoration, and then we are doing our emergence profile scan here, and then the implant scan body scan. Also, I want to repeat it, for us it's very important that we start at the middle of the palate, because we are not magnifying the errors around the arch. So this was very helpful for us. And then we have again all files, all scans in one file, and we can transfer it very easily to our technician. So you see it here, we have the lower jaw, upper jaw, emergence profile, and this in one session. So it's great because we can save our time in taking another session for taking a bite. So this is a great advantage. So I want also to present a little add-on in the digital approach. It's stereophotogrammetry. What is stereophotogrammetry?
It's not my phone.
No, I was not muting it because it's so funny. It sounds like a old computer game. And it's using the same principle, or at most almost the same principle as the dynamic navigation. So you have two cameras filming an object from two different angles. You have already handheld devices of this. And the difference between the scanner and the stereophotogrammetry is the stereophotogrammetry is seeing everything at the same time. But it's not a question if you're using an intraoral scan or stereophotogrammetry, you need both, because with the stereophotogrammetry, you can't scan the gingiva. So it's an add-on product. But you can align these two files, so both STL files, and the precision of the stereophotogrammetry is really good. We have to say that. So when we're comparing it with a conventional impression, also intraoral scanning, we see stereophotogrammetry has a very high trueness, it's very accurate. So at the moment, I would say stereophotogrammetry is a great add-on in our procedure, especially in the lower jaw. It's very, very helpful because our scans are not so easy in the lower jaw. So it's a very helpful tool at the moment. It's pretty expensive for an add-on product, but in some dynamic navigation devices, a stereophotogrammetry is already inside. So this is very nice. So you have two devices in one device. But with the improvement of our scanners, I'm not so sure if it's a game changer in the future. I think our scans will improve, and at the end, maybe it's a little bit unnecessary from my point of view. So now we are seeing on the right side our try-in bridge. Why is this so important? We always check the accuracy of our scan with a test bridge. And with the test bridge, we also can check phonetics, all adaptations we have done, the pontics. So it's a very important factor in our process. And then we're doing the final restoration. Maybe you can say something to the different options.
Generally speaking, this is the panorama we have today for the restoration of a full arch. You see on the left side the classic approach, so metal framework veneered with ceramic, but this can be also veneered by resin or composite. This is the classical way to treat this type of dentulism. In the middle, we have an evolution of this type of solution, so a zirconia framework veneered by ceramic again. And last, on the other side of the screen, you see the most, let me say, used way of doing today, that is the monolithic zirconia, so one block material for doing both the framework and the veneering material. This is very, let me say, typical, but if we want to analyze this more into detail, we have to say that starting from the metal veneered material, we need a different height. So for zirconia, it is important to have enough space to develop a design that is in line with the strength we need to resist to the masticatory forces. And when we have a reduced space, sometimes this is a choice that is strict, because we need to have resistance in our bridge. So 10 millimeters is the minimum for that type of restoration. It has a high survival rate, but it is affected very often by chipping problems, and so this is very well described in literature. The same high survival rate can be considered about the veneering ceramic and zirconia framework, not exactly the same, because we have much more literature on the side of the metallic framework, but the literature also says that we have a highest rate of chipping by using this approach that, as far as I know, is not anymore well considered by the clinician. I think this it has been almost abandoned because the monolithic zirconia has overcome, and this is an approach that a reduced amount of long-term data. This is the problem, and it has a higher fracture risk, not in terms of chipping, it is almost a solved problem, in terms of fracture of the framework, that this can be very dangerous for our patient. Another interesting point is that in order to face or reduce the risk of fracture risk, we try to make this bridge thicker. And this can lead, especially in the frontal area, in a huge and bulky structure that can affect the phonetics in a negative way. And this is another aspect that can be considered very carefully. What's your opinion?
I also think so. We're a big team, so which is doing this longer than me. So we are repairing and have many patients with bridges. They're older than 10 years. So we have a lot of problems in the repair of these bridges. So the ceramic bridge is really difficult to repair because you can't go back in the oven without risking to fall off the whole ceramic veneering. So this is a big problem from my perspective. So we started around 4 years ago to think about another concept. So we are doing a modular reconstruction architecture. What is that? So we are using very, very small titanium bars. When we have a long cantilever, we are using steel because it's more stable and you can go thinner. But titanium works very well. In this case, we have used titanium, and then we are doing a very big outside of monolithic zirconia. So we have the translucency of the monolithic zirconia, but on the other side, we have the stability of a metal bar. So this is a little bit of the advantage of both worlds. And the second thing is, you can repair it. And in the preparation of this meeting, I was finding this very nice study of Pelecanos and Alessandro Pozzi. Maybe you're here, would be a great honor. Thank you for the data. Same idea. And we are just doing it a little bit different. We just splitted the bridges, and why we have done that? So because of two reasons. Reason number one, when we have cantilevers, we have a little different flexibility we have a lot of different flexibility of our titanium or our steel and the very, very rigid monolithic zirconia above it. So we had some fractures here in the so-called veneering material. It's a thick bridge, but we had some problems because of some movement of the cantilevers compared to the bridges. So we have done, or now we are doing 3 bridges to give the material a little bit more flexibility. And the second reason why we are doing that is that we can reproduce one of these bridges. So if we have a fracture in one of these bridges, we have this data already in our laboratory software, and we can easily reproduce one of these bridges and connect it again in the laboratory. So this is a really great advantage for me. And the second one, you already mentioned phonetics. We were very often very thick with the monolithic zirconia, especially on the palatal side, because you can't go outside because of aesthetics, of course. But the problems had a lot of phonetic problems when we are getting so thick at the inside. So with this material, we can go very thin because of a very stable bar out of a metal. So this is the final restoration, and I would rate it as a game changer in our daily life because we can repair it and have a lot of advantages of 2 very good materials compared. So this is the final restoration of the patient, and we see the extraoral picture. And what I really love is that when the patient gets a transformation in the mouth, they are also changing their behavior and their self-esteem, and this is maybe the most important factor in our daily life, and it's the greatest thing when we are doing daily implant dentistry. So, Luca.
You want to show something?
We are going back to a different world. You have seen 2 beautiful cases where you had soft tissue, bone, and mutilated dentition that they decided to extract. Now, Maria, the case I showed you at the beginning, is a different thing. She has a mutilated dentition, but she has lack of bone, So it would be challenging to do an immediate loading in this case because in the posterior part of the maxilla is very thin. Still, this case was not treated by me, it was treated by my son, the digital part of the team. And according to an old concept that I have been using for many years, and I think that this should be considered, because I don't think that we can pretend that we treat all failing dentition cases by removing teeth, placing implants, and doing immediate loading simply because in some cases it's simply not possible. So we have the failing dentition and we have the horizontal bone defect in the middle and posterior maxilla. And you have seen that most of the people that are on stage would extract these teeth immediately. While I think that these teeth should be carefully maintained for the provisional phase, because this allows us to have a fixed provisional restoration supported by the teeth, to do all our diagnosis by having a provisional that can be adjusted before the placement of the implants, and moreover to place the implants, not load them, and do our augmentation in the best possible clinical situation because we don't have to load the soft tissues with removable prosthesis. And this is what he did. Of course, using the digital world, he planned everything, did the virtual check of what he was doing, but then it was much easier for him to use these teeth to check the provisional restoration in phase without placing the implants, without touching the teeth, just a small preparation, and you can check what the outcome of the case is before starting the treatment and without the need of a very, very sophisticated and long planning process. And then you can use a static guide that is supported by the teeth. So this, we all know, it's the most precise way of transferring our planning into the bone. And you see that besides the planning, we are placing the implants in a very thin residual bone. Of course, I don't think anybody in the room would like to load these implants, but we do a standard horizontal bone augmentation with GBR that allows an easy healing because we have our fixed provisional restoration that is somehow supported by the residual dentition, same situation on the other side, and then you just need to let everything heal, and then you can, as you see here, you can complete the extraction. So here the concept that I would like to outline is that we need to use the digital tools in a personalized way. There are cases where you cannot use the standard protocol, but you can still profit from the digital tools, and I think that it is mandatory to try to deliver to the patient a personalized treatment plan that in most of these mutilated dentition cases includes bone augmentation. Of course, when you have a lot of bone, when you have a lot of soft tissues, you can do many other things. You can be less invasive, but there are cases where you simply cannot place the implant at the time of presentations because there's not enough bone available. Besides, you tilt them or you do a Summers osteotome technique, but still you can profit from the digital approach. And the provisional here is just a check of the provisional phase before he went to the final restoration. And you see the final restoration in place after 2 years with a nice soft tissue conditioning that you have all the time to do, because this patient is neither without a fixed restoration and does not need any kind of immediate loading of the implants. And final restoration, as I said, after 2 years, your implants are there, and of course this could have been done with an analog approach, but the digital approach helped a lot in this case. I think that we should not think that digital tools can be used only in the standard way, extracting everything, placing the implants in cases where you have bone, but you should try to use them also when there is a need for a bone augmentation.
Right. So I want to thank you for being here so late, last session of the Congress, and I really want to say thank you to my team sitting here. Without you, I wouldn't be able to show even a single slide. It's great working with you. Thank you so much.
Please come over for the discussion.
Also from my side, a big thank you to everybody, and thank you for being here till this time, and thank you very much.
Sergio and Lucas, if you want to join us, there's a few questions that have been raised by the audience. We have a few minutes left. And one of the questions was related to the insertion torque, and you decided not to include the distal implants in the restoration. And so what about if you don't reach enough primary stability in the implants that are actually in the front area? Would you actually act the same way? Would you leave that out of the restorations?
So I think important is that it's a bridge insertion torque, so we are summing up all insertion torques. So if one implant has not a perfect primary stability, this is not a big thing. Maybe an important factor is if the distal placed implant has a low immediate primary stability, because this could be a problem in the reconstruction and the immediate loading. And you also, what's very important and we don't think of very often, you have also to adapt your occlusal concept to the primary stability of your implants. This is also important, that we have the option not to load one side more than the other, or we can load one side more than the other. So these are different things we have to think about when we are loading the implants.
So the opposing arch is a factor actually in this decision.
The opposing arch is a factor. Yes, it is a factor, but when we are looking at our data, the bridge insertion torque is a significant factor, and the opposing arch and the material which was used, or a dentition of the patient, was not a significant factor in our survival rates.
I have to say that most of the questions that came from the audience are regarding what software, what kind of... So they were very good in not showing any brand. Yes, they were very nice. But you can ask them separately later on for sure.
So there is actually, Sergio, one thing that it's in this full arch restoration, of course, CBCT is mandatory.
Yeah.
But would you suggest to apply this digital workflow that requires CBCT in any case where you place implants? Because of course this is something that is relevant in terms of exposing the patient to X-rays. So.
If we are speaking about full arch reconstruction, I think yes, it is important to have this information, because I think that there are really few cases we can place implant without having this data clear in mind. But if we are speaking of a single tooth replacement or a little area, I have to admit that several times I do without it, because there is not the case to, of course, find some information.
But not the planning, because what is I think is important
yes,
to share
course.
that the planning.
In this case, you have to go for analog, of course.
I have to say that we have limited this discussion to fixed restorations. Yes. Many of these patients at the end of the story might be treated with a removable implant-supported restoration. In that case, I think in some cases you can skip the cone beam CT. I mean, the case that you have showed in the mandible, if you did not go for a fixed restoration, you could have treated with a panoramic X-ray and an overdenture. So it depends a little bit on the level of the treatment that you want to deliver.
Mm-hmm. Because I think it's very important that the planning it's very precise, and we're not talking about the accuracy of the placement of the implant is improving. But I don't know. What do you think that this will affect actually the outcome of the treatment overall on the long term?
I think this is a very important factor, that we are perfect aligned with our teeth of our reconstruction, because I think in the cleaning of our patients and the maintenance of our patients, this is an absolutely crucial factor, that we're in a perfect position underneath our bridge, that our bridges are not getting too thick, they don't have a balcony. So I think the angulation, everything, the position is very, very important to the treatment success at the end of our reconstruction. So I think this is really important. Vail At was telling us before, the pros are the boss. It's very interesting, because I have to say this to my surgeons. I think they wouldn't agree.
Me neither.
If I can add a word, I think that the accuracy of the implant placement, the following step, is increased as soon as you have made the plan very detailed, and very often this procedure should be done by the dentist, not given to someone that is not skilled on this topic and doesn't know the clinical problem. So this is at least supervisory.
Yeah, because we don't have to go into the risk that people are outsourcing this to the labs or to third parties that plan the case and then they just execute it, because this, I think...
If you want to play safe, you have to have a very, very careful planning from the beginning to the end.
Okay, I think we need to close, because I think we are 2 minutes behind the schedule. Thanks so much, you heroes, for being here so long.